Good morning. Nothing like a bright, cheery movie on a Sunday morning to get you going. Apparently, in a session yesterday, there was a representation of some data about accents. And this is an Irish accent, so it's an island off Europe. And it came fourth in the world. And the Australian accent came first. So I have two suggestions regarding that. First, we definitely need a replication study. And the second is, best of luck, Andrew. So, what is a Renaissance? So roughly between the 14th century and the 17th century was this great period, over 300 years, of discovery, of innovation, that contributed immensely to scholarship. And those discoveries, those findings, those methods we use today. For example, the artistry and the images of anatomy we use today. You ever see those anatomical structures? And when I see them, I think, God, wouldn't it be cool to put an ultrasound probe on it? Now, it would, wouldn't it? Now, you need to all focus at me now, okay? Just look at my eyes, okay? Because, you know, that's a good analogy, isn't it? It's a good kind of descriptor. So keep focusing on me. So yesterday in the trial, apparently the ultrasound probe, keep looking at me, the ultrasound probe looked like something else. Now, once you see it, you cannot unsee it. It's a bit like a p-value in a scientific study. Once you see significance, that's it. Got a p-value. Okay. It's too early. It's Sunday morning. So, with that came a Renaissance man after that period. And of course, we would change the language. It's a Renaissance person, or perhaps a Renaissance entity. And when you think about our game, it's multi-complex. There's so many relationships involved in vascular access and infusion therapy that there is poly. There's many issues with it. And we've got great people. This is how I think Jack Ladon would look like with a beard. So I saved myself the animation. But there are many people that we would say are Renaissance people. Matt Ostroff, for example. Vineet Chopra. And we have to acknowledge, given this sentinel event at this meeting, Suzanne Levere-Herbst. Our modern-day contemporaries, Claire Rickard. And, of course, other entities, this great organization. So, if we go back 100 years, it was an awful lot simpler then. It was so simple. Small, sharp scratch. We were deciding and defining what's the best approach to treat illness. Remember, this is a period post one of the first catastrophic pandemics that has influenced our modern management of, we're not going to mention it. But when you think about it, and you read the historical events of 100 years ago, our actions were informed by the practice of 100 years ago. And sadly, because the observations are there in our medical libraries. Very little research on vascular access during COVID has been published. That's really important. And so we go to 100 years now. It's very complex. It's utterly complex. It's utterly complex, it's messy, and we're trying to process and standardize it. And I would suggest to you this morning that we standardize that with greater collaboration, greater involvement of a variety of disciplines. And our example this morning is a clinician back in the day, like myself, as someone who's gone on to do higher degree research and do clinical research, has to collaborate with various disciplines. And one would be the physiologist. If we find out what's causing the harm mechanistically, I think that's very powerful. Wouldn't you agree? Andrew, I think you might have some thoughts on that.
So thank you, Pete, and I excuse my accent. I will try to enunciate a little more clearly and not abbreviate things. How you going, for example? So thank you, Pete, and definitely to follow on from Pete's comments there around the complexity, moving from simplicity to complexity, and acknowledging the role of education and what's brought us to this point. It's really important for me to emphasise, the work of our past forefathers and foremothers, for that case. And Dutton's work, published in the form of books, is how we used to learn about anatomy, right? And it's taken us to where we are now. And this is, back in the 1920s. It's really fascinating work. And Dutton's work was really instrumental because what it did is it taught us about innovation and how we can access the venous circulation. Dutton and his colleagues came up with a number of inventions very early on in the piece, which helped us to access the venous circulation and effectively to take blood. And that led to obviously delivering blood and intravenous therapy after that. So as you can see, we use books, to learn, and this has changed, and we'll get to that in the next slide. But you can see the types of devices that these innovators, these Renaissance individuals, developed, include tourniquets. Getting my laser here, but that's fine. And you can see the tourniquet on the screen. And they also indicated and developed things like the first three-way valve on the bottom left-hand corner. These were metal devices back then. Significant innovation has occurred since then. Furthermore, you can see a number of needles that we use to access the vasculature, and each of those needles had different purposes and were named actually after the inventors. Modesty, right? So these were our, inventors. These were our common day, I guess, manufacturers even of these medical devices, and even included infusion sets. So they're really, remarkable inventions of the time. So we take the lessons, I guess, from these individuals, and now we apply them, and we extend beyond them, which is in that definition of a renaissance. So we haven't stayed static. And now what we're doing is learning using technology, not books necessarily. And as you can see, we have now a number of digital, virtual reality modalities of learning. This is amazing. Equally amazing, I would say, as reading from a book. But it's revolutionary. We now have simulation as well, so this is a constant drive to innovation. And definitely these individuals who are taking us to that level are participating in the Renaissance. They're not staying static. Surely these individuals are also part of this Renaissance that will continue, so it does make you wonder where we go from there. But it gives us really greater detail of knowledge and application. How we learn, how well we learn, and so on. But in the modern day, what's really required now is an extra level of detail. For example, if we were to implement online digital learning technologies and simulation, surely we must test whether they're effective, right? This wasn't done in the past necessarily, or if it was done in an N of 1 modality, one doctor treating one patient to assess whether it was effective. So clinical trials, observational studies, all of these things are important to creating evidence upon which decisions are made and implementation forms on the back of. So being a physiologist or a pathophysiologist, an individual who's interested in disease processes, I think it's really intriguing to look at some of these examples of innovation that have occurred in the past. And I look to the history of blood because I'm fascinated with blood and blood vessels and how they behave. So centuries ago, we understood that blood was critical to life, and some ideas came around the ability to remove blood and then transfuse someone else's blood into another human. And we can't deny how important this discovery has been. This is really exciting, or at least was at the time, and I guess we continue to innovate in this space. Previously, we used to be able to test N of 1, as I said before, top left-hand corner, the first transfusion experiments, transfusion of blood of dogs into humans. Highly risky experiments. However, this is now challenging, if not impossible, to do an N of 1 experiment with such risk associated with it. You couldn't recruit the Pope, and this is actually documented. The Pope received the first human-to-human blood transfusion. That Pope took the blood of 3 10-year-old boys who subsequently died to receive a blood transfusion. And equally, we couldn't take the Pope these days and apply the most modern stem cell therapy to that individual on an N of 1. It would simply not be possible. But it's needless to say, this led to incredible innovation, massive steps forward in medical treatment, and in some respects, vascular access as well. So we now save, thanks to this, thousands of lives every day due to blood transfusions. You can't deny that. And because of the sacrifices that were made in the past, we now save thousands of lives, as I said, every day. And that's where that sort of ethical approval process, which is now implemented, comes in to create that additional step of ethical inquiry, making sure that we're doing what's appropriate. And interesting, Pete, I'd love to ask you, what do you think the first-time insertion success rate might be in this particular experiment, which the slide has disappeared? Were they specialists, he asked? Were they vascular access specialists? That's debatable. So we move from those blood experiments and then move on to practices, which I think are equally interesting, not just the medicine, but the practices of obtaining blood and transfusing blood. And we're all big fans of the ACF, right? The antecubital fossa. So let's talk about those practices. We've been accessing the ACF for centuries. One would say we're at the point of a renaissance here. There is countless and bountiful evidence of the benefits of not accessing the ACF over a forearm vein, for example, which is deemed to be superior, right, in terms of prolonging PIBC patency and so on. But ACF cannulation remains a dogma in some institutes and some departments because it's convenient, despite the evidence. But we ask you all to be part of a renaissance and to follow guidelines, to read, innovate, implement these practices because they are based on evidence, right? Evidence that previously couldn't be generated and shared. You now have access to that. So here's to the crazy ones, because these were the individuals transfusing blood from dogs into humans, humans to humans, creating new devices that were deemed crazy, right? There was a lot of risk involved in some of the things they did. But we're all crazy, okay? These crazy innovators, Renaissance individuals that we do need to promote. We don't need to promote those very risky practices, but we need to promote the practice of thinking laterally, being open-minded, being creative, not staying within our box. Okay? And that comes from generation of knowledge, and as we'll talk later about, understanding what we don't know, okay, and generating inquiry questions. So this takes me to one of the crazy ones, and there are many of them, including Werner, who was one of the first individuals to pioneer the use of a peripherally inserted central catheter. Depends on your interpretation of these papers as to who was actually the one to insert it, but I believe it was a nurse. And you can't deny, the importance of the development of a peripherally inserted central catheter on medical care and vascular access practice. What an innovator. The inventor of a line that extends from the upper arm to the right atria has permitted now the administration of potentially toxic drugs into an environment which is mixed well. That couldn't be done before, or if it was, it irritated the vein that it was infused into, and Pete's going to continue with that discussion in a moment. So that's changed practice, right? And it's saved lives. And you all can be part of that decision-making process through your observations and thinking, what could be done here? What could be done better? Again, this experiment was risky. It carried risk. There's absolutely no doubt about it. But he was able to produce this experiment, I would imagine, through consultation with a number of his colleagues before performing this experiment, to consider many different perspectives, the risks and the benefits that existed when he performed the experiment. Okay, so bizarrely, Werner was associated as one of these crazy individuals. But guess what? He was then shared, a Nobel Prize for the discovery and the finding of what he did. And it reminds me of other notable Australians who have subsequently got onto this. He wasn't Australian, but we've had these really crazy people who have innovated and been awarded some of these most prestigious awards. And finally, I wanted to talk about an innovation in the space of cancer. This is really, really quite profound. And nurses had an important part to play in this innovation. Treating cancer began in the 1930s. And the term chemotherapy was actually derived or coined by German scientist Paul Ehrlich, who had a particular interest in alkylating agents, toxins actually, and came up with this term, chemotherapy, to describe a chemical treatment of disease. Well, guess what actually happened to take this individual here? They were observations in the First and Second World Wars, where he noticed that soldiers exposed to mustard gas became neutropenic. Toxic agent used in war reduced white blood cell counts. That innovation then led to this individual using mustard gas or derivatives of it for the treatment of lymphoma. Highly risky experiments, as you can see. Nurses in masks delivering such drugs to patients who are suspected of having lymphoma. So basically, this was a chance finding. Like, how amazing is this? The beauty of serendipity and an inquisitive mind, which led to breakthrough findings and concepts of selective toxicity and so on, which we now use routinely in clinical medicine. What's really interesting, I find, is this is not the end, right? It's an understanding. People will say, well, there was so much to learn back in the 20s, and there were. It was a simple life, right? Things were simpler. There was more to discover. But I would say that actually we're still in a phase where innovation is continuing and becomes more rapid, with more potential for further innovations. And the example I would like to give is in the area of immunotherapy, which is on the right-hand side of the screen, We're now entering a phase where it is likely, and some evidence already exists, for cures of stage 4 metastatic cancer. In this case, we take blood cells from an individual, their own blood cells, and activate the immune system, reinfuse those activated CTLs or lymphocytes, which then target cancer cells and destroy them. The future is personalised medicine, without any doubt, individualising medicine for each patient. And the point is, how do we manage that within a health system? It's incredibly challenging. So with that, I'll pass back to Pete.
So we move on to the 1950s and to Robert Aubignac, a French military surgeon who described the first insertion of a non-implantable catheter into the subclavian vein.
Yo, was it at the axillary vein?
I knew there'd be heckling. So I have a heckling app. And once it records the heckle and it converts it. Here we go. There you go. There you go.
Artificial intelligence, right?
Yeah, it's in beta, okay? But imagine if he knew that. Even at that stage, we were defining anatomical regions differently. But yet, this device is a mainstay medical device in catheter intensive care. And how many of them were used recently during COVID. And of course, these innovators, Renaissance people, have continued. And it continues to this day, contributing to catheters, nomenclature of techniques that exist today. And so we move to a little bit about complications and complications with these devices. So 1953 to 1970, it's 17 years. Okay, you didn't need to be that good at maths like myself, math. But it's the accepted timeline from discovery, evaluation, and implementation, roughly about 17 years. So in 1950, there's reported cases of septicemia with intravenous catheters. And it takes up to 17 years later for real strong action to, in the wisdom of the day, start routinely removing peripheral intravenous catheters at a time point. It's probably interference from our app. Don't worry. So this is really important, I think. And this information, we've gone back in time, and it's inspired some of the really great empirical studies that we have in vascular access, routine removal versus clinical indication. So now we've got some terminology, clinical indication. It's a new term. And we can start associating that term to other devices and other language and other mechanisms, and is categorized by implementation science, knowledge translation. So in all of these kind of discoveries, you would have expected a clinical trial for it, as Andrew had mentioned. They were unethical approaches in the past that wouldn't be accepted in modern clinical trial approaches. So here's an example of one of the first reported clinical trials where some sailors were given vitamin C and others weren't. And the mortality rate was higher in those that didn't get the vitamin C. I'm sure Florence Nightingale had her own work. It's probably still under review. So, it's probably in our inbox, probably. But you'd have to agree now, in a modern renaissance, in a modern vascular access renaissance, where we have to contribute to higher order scholarship, that there should be clinical trial evidence for the procedures we do. Cannot get away from it. Other disciplines subscribe to it. So think about it. Whole host of opportunity in the medtech innovation space to robustly evaluate these technologies. And we'll explain shortly why that is. But I think it's time to see Andrew in Queensland, Australia. So I don't know if many of you know, but not only is he a pathophysiologist, physiologist, biologist, he's also a sheep farmer. It's probably where he gets his beautiful accent talking to the sheep all day. Over to you.
To go back, there we go. Is this my talk or is it yours? I seem to be talking a lot.
I think I have the most bit to do at the end.
Okay.
We could discuss it afterwards.
Okay, all right. I'm not going to make the same joke as I made last year when I showed this slide. Yeah, the love child, exactly. In the modern age, it's really interesting, right? These additional hurdles that we have to go through, to develop these devices these days. But in the modern age, regulation, which aims to reduce risk, requires that we test a lot of our new devices now in animals first, and then we follow to human trials. And we respect that, it's really important. This is all well and good. However, it does delay that development cycle. There are more experiments to complete, right? And in many respects, this does increase the complexity and the need for collaboration again. This wasn't required previously. Now you have to bring in more individuals to conduct those experiments. And the thing is here, this is really interesting because the complexity is that we assume that animal responses, which are studied in the early phase of development, reflect human responses. Right? It's a big assumption to make, a huge assumption to make. So it reduces risk, but it introduces complexity. And those studies are really important, From my perspective, understanding how the human body works, not so much how animal physiology works, but there is some crosstalk. It provides really early information on mechanisms. It's the how, right? And it's really important to the development process. And we believe that collaboration with ourselves, veterinary scientists in this case, biologists, biomedical engineers, so many individuals at this stage is really vital to accelerating the development and innovation. So it's important to note, however, that these early phase studies can also be conducted in humans. And my personal feeling is, and it's reflected in the ISO statements, international standards for testing, that human testing is preferred over animal testing if it can be conducted. If the risk is minimal and you can get your approval from the ethics committee to do so. But in most cases, this is entirely possible. And the beauty of doing that is that you have more confidence in the experiment, like these early innovators who are practicing in patients to move and develop the cycle forward. So I just want to emphasize animal testing is important, adds valuable information in terms of safety, but to accelerate the innovation, we need to provide early trials in humans prior to rolling out those clinical trials or those trials in larger clinical populations. It will improve the certainty that we have in the innovations that we're developing. And a really good example of innovation in this space currently, and I'll talk more about this as Professor Amanda Ullman will also during this conference, is in the area of PICC materials. You know, we're in a time now where you have many different materials and PICCs to choose from, right? These aren't real PICCs, these are just polymers, and it's a pretty picture, but you know what I'm talking about, right? Being on the bedside, there's a number you can choose from, potentially. And it's very difficult, though, when you look at the literature, to find early data, whether it be animal or human data, on PICC materials. It is almost impossible. We've surveyed it. Okay? But this is really important to have this information. It provides many individuals, clinicians, researchers, healthcare purchasers, okay, with decisions, information to decide what is most effective for our hospital, for our particular patient group, for example. So making this information available and publishing it within the scientific literature is vital to accelerating the development process, okay? And testing them, obviously, in humans if we have that ability to do it before rolling them out into large clinical trials. Although I don't consider myself an innovator necessarily, there are examples. I think I need to press play on this. There we go. There are examples of innovative application of technologies in the space of vascular access. As you know, despite the use of PIVCs and vascular access devices for decades, we still really don't know why these devices stop working. There are many assumptions, but there's no evidence necessarily to prove it. You know, and some of the causes of failure of these devices are phlebitis and thrombosis, as you can see here. Our research group has specialised in the adoption of ultrasound and the application of really innovative methods to assess the vein and vascular access devices, to see beneath the skin, inside the vessel, and this is revealing very novel information. We're uncovering a new level of knowledge in terms of the etiology of catheter failure and thrombophlebitis. And that allows us now to innovate and test new interventions to prevent that. This is really an amazing technology, okay, example of innovation of a technology. We didn't make the technology, we just applied it from another modality. So with the development of these really sensitive tools, we can very accurately track catheter tip motion. You can see the catheter here in white. Infusion dynamics of flow coming out and the surface of the vein that interacts with that. And localized thrombus formation, which you can see in red. And this is one of our participants' veins, modeled in 3D. We call it segmentation. And now we're applying artificial intelligence to this, to utilize software to accurately diagnose, if you like, or at least quantify the actual thrombus volume of that without requiring a human to do it. AI, no doubt, is the future with machine learning. So I'd like to acknowledge not only, great members of our group that have pioneered that, Reese, if you're out there, but also authors in the US, they're in the audience, and also Japanese authors who are beginning to implement, or at least use ultrasound within their research to prove and provide greater detail around the effectiveness of some of the interventions they're applying. I think it's back over to you, isn't it, Pete?
Yeah, your last one.
Oh, my apologies.
2.
So we talk about human factors research, and again, this comes back to the development cycle within development of these devices. And what you'll see here is that human requirement or human input is common, okay, to every single phase of the development cycle. And it requires different people to do that. So coming back to Pete's point about you need a team with many different skills and abilities. So you'll see at the early concept and development phase, which is the first third, that you need clinicians to come up with the ideas and the problems. You can't solve a problem without identifying it in the first place. Okay, and maybe there's engineers there to say, oh yeah, maybe you could do this, you could do that. The idea is then passed on to engineers, which is really the design. So the idea is given to them and they say, well, you could engineer it in this way and create it that way and this could be better, but then you need the interaction of the clinician to say whether that's going to work or not. Okay, in their space. And then finally, on the right-hand side, you've got the prototyping and the testing, right? So then you've got to make it, requires different engineers again, and you need biologists, researchers, clinical trialists to actually action that. Go and test it, generate the evidence, and report it. And that's no mean feat, by the way. So what's important is that humans, as I said, exist in the middle. And so many people are required, again, not practiced necessarily to the same extent historically. And this cycle is really quite important. An understanding that there is not just one cycle, but this cycle must repeat, and this is innovation. This is the Renaissance. It's the ability to continue to innovate. And taking from the words of Donald Rumsfeld, he has some quotes around this which really accurately reflect this. So what he's indicated is that there are known knowns, right? There are things that we know. There is the documented literature, okay, that catheter insertion results in thrombophlebitis. We know that. But there are known unknowns. An example of that is that we don't know why thrombophlebitis is caused by a particular medical device or agent that is infused, right? And this is where that cycle continues around again. So we have a new idea. A catheter material seems to be associated with thrombophlebitis or a drug. What can we do? What can we design to overcome that issue and test it? And then there are those scary things. There are the unknown unknowns. So we don't know in many respects what we don't know. And that requires a really open and innovative mind, like the individuals in war who saw that the mustard gases actually reduced white blood cell counts. There are these serendipitous moments that we must keep our mind open to within our own practice to say, hey, I've never seen that before. And that creates a new question and the innovation continues. So it's a really important point to reflect on. And at the end of the day, this ECG trace reflects the heart, right? The heart of this whole process, which again is humans, but I think reiterating the fact that from my perspective, perhaps I'm a little bit biased, it'd be great to have biologists within that process and physiologists within the process, working with clinicians, working with industry, working with engineers, health economists, statisticians, so that we can work together to continue this drive and renaissance.
Thanks, man. So surely there's going to be a cost to this. There's going to be a huge cost with device discovery, with the implementation of that. And we're in an era now where we have to accept a value-based healthcare model. And for example, in 1923, how was healthcare charged to that population? It's an awful lot different now. You leave Ireland, people say, have you got your healthcare insurance in case anything happens in America? Does that make sense? And then there's an ethical discussion around that, in health, public health, free health, equity, access, as in access to the healthcare providers, as opposed to vascular access. But I like this analogy, this accepted definition of value-based healthcare. And if we think about this for the vascular access devices we insert in our patients, we want to know which vascular access interventions work. And those that work less well, we need to consider not adopting them. And certainly the ones that cause harm, we need to eliminate them. So what approaches immediately cause harm in our vascular access? There's acute insertion approaches, removal of central venous access device, and these never events. But we have accepted over time that the phrase, the peripheral intravenous catheter, is often referred to as the illegitimate child in the family of vascular access. I wasn't going to say the word. I said it yesterday. Ireland lost in the rugby. But we have to really think about that. And I think that we're willfully blind about the failure that's happening. In 2015, Dr. Robert Helm wrote a great paper, Accepted but Unacceptable, with a subsequent paper a few years later. And I think the challenge for us now is to accept that there's multi-complex factors involved in the delivery of healthcare. But as you've seen in our opening film, healthcare would collapse without vascular access and intravenous therapy. And if you arrive and accept that logic, I think, or at least I would like to test, that the health service delivery approach should we be with a specialist entity. And how we define it and describe it is up to us. So if you look at Forsman, Obeniak, and these people Seldinger, have developed their devices and technology. This is a word cloud from over 6,000 papers on central venous access. And look at how many connected words there are to complication. Like, it is absolutely phenomenal. It is a phenomenon, and it's phenomenal. It's phenomenal. Like, it's very busy. It's very complex. You think an individual discipline is going to sort that out? It's a big job for the quality improvement. That's all I think. The quality improvement team have a big job. There's certainly evidence of people doing that really well. People in infection control contributing to improvement science. Part of the team. So it's game day today, right? Now, my education on American football isn't great, but I know this is a really good soccer player. And what's so funny? Okay. About 10% of you actually believe me. But when you think about it, how good are the Patriots doing now? So who's in the team? Is it the inserter? Is the inserter driving it? Is the inserter building all the momentum? Are they doing the assessment, the referral, the decision-making, the data science, liaising with the physiologist, coordinating the clinical trial, discussing with medical device technology startups, giving them advice, going to litigation with Russ? About 7 years ago, one of the highlights of my academic career was getting the privilege to present in Florida on a Cochrane review. So a Cochrane review is accepted as one of the highest methodological standards in evidence synthesis. And Archie Cochrane said that it is a great shame that we have not compiled by speciality or subspeciality all the clinical trials in our area. And I think it's the same for vascular access teams and for the clinical trials in vascular access as well, in PIVCs, PICs, CVCs, dressings, and so on. I think I did say at the time, if there wasn't any randomized controlled trials, I wasn't going to come back, so that I'm glad I've come back. So we need to work on that, and we have we have a value-based argument? Do we have to make an economic argument to bring these teams? And one really important point, since 2018, we're writing about this. I don't see many clinical trials evaluating what team approach works, what works less well, and what's causing harm. Wouldn't it be amazing if we brought all the vascular access literature in one place in 2030? And we go, oh, that team in America does it different to the team in Europe. They're using that device and we're using this device. And teams are really important because healthcare wants to know what is the better, cost-effective model. And I think this is really important. And I would like to see a greater understanding of what the definition teams are. In Ireland, intravenous teams have commenced again. Now, I think a show of hands, would you agree that's a great thing? So, I had nothing to do with it. Should they be putting in all the vascular access devices? So if I said that a majority of the work was surveillance, is that a missed opportunity? So you've got to understand when people say we've got IV teams, it doesn't solve the problem. And all we're suggesting is that there's a time for a reboot and we need to find out what works better or what's causing harm. Having a team going around feeding the cannula monster won't cut it. Our first-time insertion success will be great, but we're still going to be putting in more catheters. Device appropriateness. Has anyone read this Cochrane review on ultrasound-guided approaches? Has anyone read, show of hands please, anyone read Ulysses? It's a famous Irish book. You'd nearly have to read it 50,000 times to try and get it. It's very complex. But when I read this paper, I think, what are the people putting the catheter in for? Are they in a team or not? And if they're in a team, is that the most appropriate device? And the summation of this is, we need better clinical trials to prove that ultrasound is superior than landmark. Now, I know you know that that's crazy, Pete. It means that the people that are putting it in don't understand it. Make sense? And that's why I think there should be a reboot on this. Like, you gotta think, podiatric medicine moves from the knee to the toe. That's an accepted discipline in healthcare, podiatric medicine. If you fall, do a hip, you're going to be seen by an orthopod. They look after bones. You have some chest pain, when the trial doesn't work, you might see a cardiologist. You're in a study, they're given the wrong results, you might get a headache. You might have to see a neurologist. But any Tom, Dick, or Harriet can have a go at veins. What a wonderful world. And so, when you think about it, it's going to be up to us. You heard from Gillian and Mavida about collaborations internationally yesterday. That's the exciting bit, in my view. So, while it might be a eulogy, if you like, and a bit of prophet-type speak, we've huge challenges in our own discipline. If you think and accept that the literature will say 50% of peripheral intravenous catheters inserted in the emergency department were not clinically indicated, how much unnecessary waste have we burnt? This is the biggest challenge we have, is climate change. And if you accept 4 to 5% of all clinical waste is contributing to problems with the ozone layer, then it's up on us to drive that on. So not only do we have the implementation scientists in, for example, infection control, we also have a responsibility to achieve sustainable development goals. It's up to us. And we're not going to do this without proper collaboration. We've mentioned it and reiterated it. And in the last 10 years, you can see the breadth of professional here, from front-facing nurses to device technologists, engineers, physiologists, academics, people in public involved, support groups. It's amazing. But we need it. And these not only is a responsibility for us on sustainable development goals, but we've got to get our data correct. If any of you recall San Antonio, we're in the lobby, 2013, I think, 2012. And we're in the lobby and there's guys saying, what do you do? We're at a meeting. And he said, oh, we're at a meeting about oil, about drilling for oil. What do you guys do? And one of our colleagues said, we drill for blood. So we had a good night. But if you think after the Renaissance, oil was the most important commodity, and I'll put it to you now, that data is the most important commodity. It's what's going to happen. It's what's going to help us identify value-based healthcare, what works, what doesn't work, and what's causing harm. And are we measuring the vein? Are we measuring the device itself? The therapies that are going in? What chemotherapeutic agents are working, peripherally versus centrally? What's happening to the vein, the anatomical structures itself with new technologies and moving them elsewhere? And of course, the process. So Andrew and I have come up with a really exciting technology that we're really excited to share with you this morning. And it is in beta, so it's about to get approval. I hope it'll be ethically approved. But it's to help disseminate our information. And no one has thought of this before. So we've got a website called Only Cans. And in Only Cans, we're going to show the best practice about insertion success.
It's quite uplifting, isn't it?
It is uplifting. Now, I don't know if we'll be doing multiple insertions or if we'll be doing just the one. But if you'll allow us to indulge you just for a second, the point is that information is now in your hands. Information is now in the cloud, and there's going to be a cost with that information. Data storage is a cost. It has a cost, a CO2 cost. And when we flew over from Dublin to Seattle, there's loads of information in the cloud. And that's where it's going to be. And we've got to be literate on it. So you would have heard the phrase during this meeting, Pandora's box with AI intelligent data, and using that to the best advantage of the people that we look after. But is it going to be Pandora's box? And what will that mean? Or is it going to be our holy grail? And it'll be up to us, in our teams or in our healthcare, to decide how we use that. Hands up who works in a hospital where you've got multiple informatic systems that don't talk to each other after maybe 50 million emails to another person. Yeah, it's crazy. About 20 years ago, coming back from Australia, I stopped off at San Francisco, and I picked up a book in the airport, and it was a book about a really brilliant politician in America called John F. Kennedy. And of course, I was drawn to the Irish connection to it. But in each chapter of the book, An Unfinished Life, there was a quote, and I circled this quote. And I think it's quite apt from what Andrew has said and what all these other innovators and Renaissance people have done. They've found something. And I think we have to understand in our area that we're finding stuff and we can own it for the betterment of the people that we look after. And then we've got to translate it, implement it, evaluate it. It will go from what we would call the bench to the bedside. But imagine how much we could narrow that 17-year window if we've got the people in the vascular access team. And they can be in ICU, in radiology, in ED, in cancer, but they're speaking the language. There's a consistency with our approach. And so it brings us to thinking what will happen in the future. What would happen in 2030? Will it be the same? Minor improvements? What will our BSI rates be like? What will our thrombosis be like? Will we eventually realize that the fibroelastic sleeve could be thrombus? Maybe the AI will tell us. Maybe there will be more time dedicated to expert insertion, and AI can do the data analysis. So, to conclude, these presentations don't happen without teamwork. And Troy and the team back here help with that. Without them, the audio and the effects with the music wouldn't work. When we send in our slides in May to Tanya and Jill, and then they give us an opportunity to change them at the 11th hour, that's teamwork. It probably helps that you've got the accent is #1 in the world, so that's on you, Andrew. But one last reminder, you cannot excuse the work you do. And you have to remind yourself, and whether you accept this as being sycophantic or, as I said, evangelical, Father Peter. But the work we do is profound. Remind yourself of that. It's a privilege to put devices into human anatomy. It's a privilege to improve it, the process. It's a privilege to lead clinical studies. The work we do is profound. And finally, 2 great women left the earth. One was Suzanne Levere Herbst, and what a legacy. And the other was a brilliant poet, philosopher, songwriter in Ireland, Sinead O'Connor. And we've got a little tribute for you.
Thank you for hearing me. 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 Thank you for loving sweet.